for this month's HIIN monthly call. This is Karen Kennedy, and I'm actually off-site right now, and I'm joined at the Indianapolis office with my colleagues. I just want to make sure that you can hear me. Annette, can you hear me?
Can everybody hear us in Indy all right?
Yes, I can hear. This is Karen. Can you hear me?
I can hear. Okay.
Yay! All right.
What slide would you like to be on?
Well, good afternoon, everyone. This is Karen Kennedy, and thank you for joining us for the HIIN monthly call. I think this is my take 3, and then I realized that no one could hear me each time. So thank you for your patience as we work through some technical difficulty. So we're here today just to provide a HIIN update with you, and then actually we have some hospitals that are going to share with some of their stories and successes that they've had in some of the harm topics. So again, thank you for joining us, and thank you in advance to the hospitals that will be sharing today. So as we always start, our mission is to advance health in Indiana, and we're here to engage and inspire healthcare providers and create safe cultures, create reliable systems of care, and ultimately to prevent patient harm in Indiana. So I think Becky Hancock's going to be sharing some of our results that we have to date for our HIIN, and it's definitely seen some great results and where we've been preventing patient harm in Indiana. We definitely need to take time and celebrate those successes. So, but before we get into the data component, I know that we've been getting calls about, what will happen with the HIIN after March of 2020. It will conclude. I know that for those who have been on this journey with us for the beginning, since 2012 or even 2011, we always have that, we're going to get news and we're pretty sure it's going to continue. But just the way that the CMS has set up these projects, they do have to end at some point. And then CMS has to put out a new request for proposal, and that's what we're hearing that CMS is intending to do. We haven't actually seen that and what that work will look like, but the HIIN as we know it today is scheduled to end on March 31st. So while that's a time for us to pause and celebrate and okay, what's next on the horizon? I'm just going to walk through just, kind of what we see on the immediate horizon. But first of all, you'll see these bullet points. The biggest takeaway, though, I want to share with you is that IHA is going to continue to support our members and patient safety. How that looks and feels, as we proceed forward, I think it's still unknown, but we will be here to support you. The first immediate thing that we plan to do is to send everyone your final improvement calculator, and that'll be based on just the data that you've submitted, up to the end of the HIIN. We are hearing that HRET, and we do know that HRET is will be shutting down the Comprehensive Data System, or CDS, on March 31st, and they are saying that it will open again, and we're still learning those details, so it's kind of an unknown when that will happen. As I said, we will continue to support members, especially, if you're, struggling with, with falls with injury. We'll be able to deploy Madeline out to your facility or on a call, and to help and assist you. And I just use that as an example because, Madeline Wilson is our falls lead. And same with the, surgical safety. And that's open office hours are going to continue after March 31st. And sepsis, reducing mortality related to sepsis, our readmissions work. Those are just examples of things that we plan to continue to offer as we move forward in this period of uncertainty and what's going to happen next. And as I said, Annette and I were at the CMS Quality Conference last week, and they were talking about a new hospital and what's being referred to as a task order. So we do anticipate that there will be more hospital work that CMS will be focusing on, and hopefully we'll be able to get some additional funding with that work. I want everyone, though, if you could, save the date on March 19th. That is our annual Patient Safety Summit, and that's where we're going to take time during the Patient Safety Summit to celebrate our successes. And we do plan to recognize hospitals in different ways. One, we think it's important that hospitals that have been submitting data during this 3-year HIIN program, that you get recognized, as well as if you hit the reduction goal in a harm topic, we want to recognize your hospital. And if you maintain 0 throughout the course of the HIIN, we want to celebrate that with you. And overall, we'll be celebrating the success as our state, taking that theme of Indiana One, or One Indiana, that we are united together as hospitals to reduce harm and to improve safety in all Indiana hospitals. We are going to continue to encourage you to submit case studies. That is something also that we want to incorporate into our Patient Safety Summit this year. And so a lot of this is more to come and more details, but just want to give you kind of some insight on what we're thinking right now. So as we move forward, we do have some asks of you. One is we ask that you celebrate with your staff. Definitely, give your staff recognition and kudos, especially if you hit that mark of reducing falls with injury or reducing your central line utilization rates, reducing readmissions. I think everyone has something to celebrate, and you need to take time to do that. We do ask that you review your data for any gaps or data validation issues by March 15th. One of our goals as the IHA team is we want to finish this HIIN project as strong as we can. So we're going to be going through some of those data gaps and validation exercises as well. We will be actually downloading all the data in CDS, so IHA will have the whole data set available. So if we need to go back and you need to reference something for your hospital, we will have that. But we do encourage you to go into CDS and download your data as well. We are hearing from HRET that they will be pulling down their website. So if there's any kind of resources out there, we encourage you to download those. And certainly that's something IHA is going to be doing too. So if you don't get to that, our goal is to have that available for you. And then we also encourage you to continue collecting data on the current measures. And we are setting up a system within IHA where we can actually collect that data and you can submit it to us, because it is really important to us. As we said, we want to continue this work, but to be able to do that as a state, as that kind of that one Indiana, we will need to, continue to have data. And then because the HRET NHSN user group will be ending as well, we are asking that you join the IHA NHSN user group, and Annette's going to share some details on how you can do that. And some of you actually have already done that, so it just would be an exercise for some of you. So with that, we will open it up at the end for questions, but feel free, if you have questions, to put those into the chat function right now, and we'll certainly answer those as we go, and then at the end we'll have time to chat as well. So with that, I'm going to turn it over to Becky Hancock, who is going to talk about our data. Becky?
Thank you, Karen. For those of you who know me, I tend to talk real fast, but I'm going to talk slowly because this is very important data time period for us here. First of all, as we always let you know when there's an improvement calculator update, and the last one was December 11th, but there's some features of this one that I'm going to go over in a little more detail for you. And first of all, a mention of what our data submission expectations are, that by March 15th, you would have your final data through December of 2019 and readmissions through November of 2019. Many of you already have this data in, and we thank you for that, but that is our goal, to have everything through December and then November for readmissions. And then we can have a full year 2019 to reveal progress on our HIIN work. Let's take a look at what our Indiana project results to date are. And this is comparing our HIIN baseline and their varying baseline time periods per indicator to our total results from October of 2016 through November of 2019. So overall, comparing baseline to project to date, we are looking right now at a number of very well achieved areas that we met our 20% goal, and particularly also making progress in the yellow. So green's achieved and yellow is making progress. ADEs were doing very well with 17 to 37% essentially of progress there. CAUTI rates, everything is making progress to achieve, particularly our CAUTIs in the ICU is achieving 23% reduction from comparing those two time periods, which we're very thankful for all your work there. CLABSI across all settings and also in just ICUs, we're looking at 25 and 30% reduction. Both ICU for CAUTI and CLABSI, there's a little more progress than there is in all settings. And we also had several hospitals who participated in the ARC ICU CAUTI-CLABSI improvement program. So dual opportunities to improve and some great outcomes there. Our falls with injury, we're achieving over 20% at about 22% reduction. We're very excited about that. And pressure ulcer prevalence, we are showing worsening here, but there's a lot of variability in the data collection processes, and we need to do some more validation as we're trying. But anyway, moving on to the PSI of stage 3 ulcer, we are at about 11% reduction there, which is very good also. Not quite to our 20%, but we know that we're making progress, in, as well with our SSIs. And I know that we've had many programs that you've participated in with 12% reduction in SSI colons and SSI abdominal hysterectomies, achieving at 26%. C. diff, another one that we're very excited about, achieved at 25%. Post-op sepsis, we are making progress. That's better than we were in the beginning. We weren't making any progress to start with, so that's moving along. And we're worsening less than we were on hospital onset sepsis mortality, so that's moving along, as well as if we take a look at some of these, and I'll show you how to do a different comparison of the numbers. PVAP, we're at essentially rounding up to 20%. VTE, we still have opportunities. And readmissions, we're at between 2 and 3% improved, with Medicare about 2% and readmissions at 3%. We're not quite where we wanted to be with that, and if you take a look at your individual graph, I think we'll see that kind of 2019 was a bit of a bear for all of us on our readmissions. But we're looking at a total of $147 million in cost savings 14,135 harms prevented, and 946 lives saved. And this is just a portion of what we will be celebrating at our May 19th Patient Safety Summit, because this isn't even all of our data yet. So this is a big celebration for us all, and note that this is for internal purposes only and not for public distribution as per our CMS instructions regarding this particular grant. So this is internal sharing, not to be shared outside. When you add up all those different metrics, and you take a look at, in the improvement calculator, there's always been a tab of harms per discharge. And what you can see from our baseline, which on this is indicated as October of 2016, in comparing October of 2016 to October of 2019, just those 2 time points in a 3-year period, it's 18% improvement over baseline. So we're almost there. And if we were to have a great improvement down in November, this next one, we could probably hit the 20% comparing those 2 time points. And we're looking forward to hopefully seeing that. I wanted to point out a slicer feature that is in the latest improvement calculator, and it's pretty keen if you ask me. On the CEO dashboard tab, which is one of the tabs on there where you see, and this is what we share with you when we send the PDF. On the left-hand side of it, they've added a slicer, and you can compare different time periods. For example, if you know that you had you identified in C. diff that your peaks were great in 2018 and kind of high, and you want to compare 2018 as your baseline to 2019, you can hold down the control key and click under baseline period the 12 months in 2018, and then on the monitoring period, click the 12 months in 2019, and that will show your CEO dashboard just comparing those 2 time frames. Your total dollars saved may be more or less depending on how you were doing with that, but it will show the percent improvement will be very different looking at project to date compared to, say, a 1-year period. So what you'll see is it'll make a big difference in your percent improvement, and probably lesser in your total dollars saved, because you're only looking at a 12-month period instead of a 3-year period. But anyway, wanted you to know that there. I was chastised by Beth Wallace for not sharing this earlier, and our previous data analyst would certainly have done that. So I'm trying to make up some ground with you there, Beth.
She also asked, will
IHA have a harm calculator that we can use to calculate our improvements? We have not addressed that yet within how we're going to prepare data. It's a very good question. I know you're an avid user, Beth, and we'll have to table that question as we continue to evolve our data collection processes here. And thank you for that wonderful question. I know you report your dashboard monthly to your quality department. So anyway, a couple other things I want to point out on there is the references tab at the bottom will show you what the percent mortality is for each indicator, and also the dollar cost of each indicator. And you have to unhide 2 tabs, the total harms per discharge and the summary table per discharge tabs. They're hidden. All you do is put your cursor over the tabs, right click, and you can unhide those for your individual hospital if you are the one downloading from the CDS and using your own calculator. So nice feature, and thank you. And I believe I am going to pass this on to the next person, and that is Annette.
Okay, pick me. Yes, thank you so much, Becky, for that great overview, and thank you all so much, because this is your work that we're able to report out, and it's just a demonstration of the dedication that you and your teams have to this. As Karen mentioned, we're very dedicated to continuing to monitor the measures and the performance of our Indiana partners, our hospital partners, but until we know kind of, the direction of full data platforms, we want you to go back to your NHSN administrators within your organizations and just double check. And as was mentioned earlier, many of you have already done this, but if you could just double check for us that you have conferred rights to the IHA user group within NHSN, that will permit us to, kind of do a state of the state, if you will, and then we can also pull down your individual hospital performance for those measures that you are reporting to NHSN. This does not mean that we are asking you to report anything additionally that you are not currently reporting, but it just does give us access to what you are reporting. And so by doing so, you will utilize the group ID of 27029, and then the joining password is capital IHA, lowercase access. So if you have any questions, please feel free to reach out to me and I can walk your folks through. But again, your NHSN administrator within your hospital is your key contact for this particular task that we're asking of you. So with that, I think Madeline's going to share some information with you.
So good afternoon, everybody, and I want to make the same statement that Becky and Annette and Karen have all said, so I get my turn, and that is to thank you all for your hard work with this harm reduction and prevention. And so many of you have joined sprints and collaboratives and round tables and square tables and webinars and office hours and things just to find a way to, help keep your patients safe. And, your work is outstanding, and we want nothing more than to celebrate you and tell your story to everybody, and also be able to learn from each other for those who still are searching for that magic answer, so to speak. So that's my plug in saying thank you and to let you know how much you are appreciated. Just wanted to give you an update. We did send out information several times for wound care education. That is for all HIIN hospitals, and it is on this Thursday. We didn't have as many people sign up as we have had in the past. If you, for some reason, had missed that, please feel free to reach out to me. We can still work in. We do have some seats available. This is not the same wound training that we had last year. We had 2 sessions last year. This is a different one, and this one will focus on the 2019 International Clinical Practice Guidelines, and we will also talk about prevalence reporting and tracking and how-tos with that. And I think that, I actually talked with Nancy Morgan, who is our trainer, about this, since we have had our fair share of struggles in Indiana with the prevalence. And as you saw when Becky shared the data, some of that is very much related to how we're reporting. And so just to get us on track so we can really have a good reflection of the work that we're doing, she's going to share a little bit of her wisdom and insight on prevalence. So anyway, as I said, if you missed that memo, please feel free to shoot me an email, and we can get a member or 2 of your team still in on Thursday. That is no cost to you as a HIIN participant. Next, I'm really excited about this part, and this is the topic sharing part, and we have some phenomenal speakers today who are going to share their great improvement works. And we're going to start off first with ADE opioids, and we would like to welcome LaWanda Jones, who is from the Methodist Hospital System up in Gary, Indiana, and they have done some great work with opioids. And so, LaWanda, I would like to open the floor to you.
Good afternoon, everybody, and thank you for inviting me to share the great work that we've done here at Methodist Hospitals. And I've actually looking at our run sheet, and I'm even like, wow, when I'm looking at the data. But just to tell you that our journey has absolutely been that. It's been a journey. The gains that we've made this past period, they didn't just happen by chance. It was deliberate, and it was a lot of teamwork. And so when we started our journey, we first looked at those type of practices that, we could impact on our end when we talk about the interdisciplinary team. And one of the things that we identified, it was just some of just the common practices that nurses had by just like pulling Narcan and having it available. And that was one of the first things that we changed practice with, and we saw a little bit of a bump in our ADEs with our opioids. And so once from a pharmacy standpoint and working with nursing, we've gained as much traction as we possibly could, because for every use of Narcan, we review every use of Narcan. And we knew that the only way that we could really make the type of changes we needed to see is we really needed to get our physicians involved. And so, as I said, once we've did everything that we could do with the nursing staff and pharmacy and changing our practices, we took it to the docs, because we were taking the data to the docs, but they weren't as engaged as we would like them to be. And so I'm also, as over quality, we coordinate the peer review activity. In our peer review activities, we also have indicators that the doctors monitor and see how we're doing in improvement work. And this was one of the things that we took to the physicians. And so for every case that does not meet the appropriate use of Narcan, that actually goes to our physicians. And any type of procedural cases, our medical director of anesthesia reviews those. And any outside of the procedural areas, we have the designee from medicine that actually reviews those cases. And they've actually changed some of their practices, and I'll give you an example. With our surgical cases, we noted in the drill down, the anesthesiologist noted in the drill down, we were seeing an increased use in patients that had a spinal procedure. But as we looked at through the different phases of medication administration, we found that the patients were on the appropriate analgesics, they were receiving the appropriate doses, and then we looked at what happened preoperatively. And what we found out is that the spine surgeons had started using the ERAS criteria for anesthesia, which really was not appropriate for those patients. And so they corrected those practices. And so I think that's probably been the biggest component of our success, is actually getting the physicians involved, because as I said, I was just looking at our data, and I saw that we've actually, like for the past couple of months, we've actually had like 0 cases. And like I said, I think it's been a team effort, but actually getting the physicians involved, really drilling down, looking at their practices, and making changes as necessary. That's really what's helped us achieve what we've achieved.
Thank you so much, LaWanda. I appreciate that. And if anyone has any questions or comments for LaWanda or the team from Methodist, please do feel free to use the chat. And I just want to give you all a little bit of love from the IHA team that, as we were taking a look at your data, when we just looked at, we segmented out calendar year 2019, you had half of the year, or 6 months, you were below the project target for that 20% reduction. And as you mentioned, in January, you had 0 events. So I think that, when we look at that state improvement calculator for a total of over 20% reduction, things like this are really helping to drive that. So thanks, LaWanda.
Thank you, Annette. And this is Becky, and I'm going to turn it over to Laura Gillespie, who is the St. Joseph Mishawaka Medical Center clinical pharmacist there. And I just unshared my slides. And Laura, if you want to go ahead and share your slides at this point, the stage will be yours. And Laura is going to share on their work on C. diff initiatives at St. Joseph Medical Center. Laura?
Hi, thank you. Can you see my slide okay?
Yes.
Okay, perfect. Okay, so I'm going to talk about our journey with C. diff and some of the great initiatives and work that we've been doing here at St. Joe. So first of all, we have MedMind as our program to look at antibiotics and antibiotic trending. And I think it was about Q3 of 2019 that I was looking at our oral vancomycin use. And I don't usually focus on that too much, but I noticed at that point we had just really plummeted in our oral vanco use. So I was like, wow, this looks like an interesting story that's being told here. So I dug a little bit deeper because, you know, sometimes you get into the mode where you're just doing initiatives and working, and then, you know, you stop and you're like, wow, this is really making such a big impact. So I was kind of looking, of course, you know, when the new C. diff guidelines came out, and the emphasis was to start oral vanco as the first line of therapy as opposed to Flagyl. Of course, our oral vanco use went up, so that was obvious. But, you know, I was thinking, wow, I think we're really testing patients a little bit more appropriately, and we're treating less false positives and only when necessary. And, you know, concomitantly, we're seeing C. diff rates were also declining. So I got together with infection prevention and asked what all of our C. diff rates were, or I should say our hospital-acquired C. diff rates for all the months in December or in 2019. So as you can see, the trend line really plummeted quite steeply. So then I created this next graph here, and I thought, wow, wouldn't it be neat to kind of see if there is a correlation with some of the initiatives that we're doing? And I think I'm really going to keep doing this. Just every time I do a new initiative that could potentially impact our C. diff rates, I'm just going to plot it along with this graph of our hospital-acquired and then also our healthcare-associated C. diff cases that we see. So I'm going to talk about a couple of these. And also on the left-hand side, you can see in 2018, we had 32. I was trying to work with the numbers. We had somewhere between 32 to 35. There were a couple patients missing, but somewhere in there. And we had about a 45% decrease in our hospital-acquired C. diff from going to 2018 to 2019. So I first started tracking in Q4. Of course, the new C. diff guidelines were just published, like I said, and we were doing a lot of work putting C. diff education into place at this time, just kind of getting it started. So this is what this looked like. It was one of the handouts or pamphlets that we made, and we blew this up and put it, we call them our patient eggs. So basically on the floor, in the middle of all of our patient floors, we have what's called an egg, and it's where the prescribers are usually dictating notes or writing progress notes, and where a lot of collaboration between the practitioners occurs. So we put this in there, and basically to talk about when do we diagnose, why it's important to test if somebody looks like they might have C. diff when they first come into the hospital, why we've got that 48-hour window to test them and to get an accurate result. And then also we were looking at a lot of physicians were ordering just a C. diff PCR. And so at that time we had, I forgot what the exact name of the test is, but it was basically an EIA or an EIA with reflex to PCR. And then we also had the option of doing just a PCR. So a lot of physicians were just doing PCR, which really just indicates possibly could be just colonization. So we did a lot of education on, hey, let's not do just that. You also need to look at the EIA with reflex so that you can look at the antigen and the toxin. And if one of those is positive, then it can reflex onto the C. diff PCR as well. So we first had put those up. Then in Q1, I was really excited. We had been working really hard for a very long time on starting a penicillin skin testing program. So we did implement that in January, and since then we've tested about 100 patients now, and it's really helped us utilize more narrow spectrum antibiotics. There are certain cases, one good example is an MSSA bacteremia. When a patient has a penicillin allergy, we can sometimes steer away from the drug of choice, which would be nafcillin or Ansef, and use vancomycin instead. And, you know, studies show that there's a 43% higher incidence of mortality when you use vanco instead of the first-line agent. So, you know, we focus on those types of patients or those patients where we can really narrow our spectrum of antibiotics and get the patient out the door quicker. So I was really excited when we implemented that. And then two big things happened in Q2 of 2019. The first was we worked really closely with our microlab for quite some time to really look at which testing we should use for C. diff. So instead of the EIA with reflex to PCR, we now use a test where we look at the PCR first. If the PCR is positive, then we know that the patient is colonized, and then it reflexes over to toxins. If the patient does not have active toxin production at the time, then we know they are simply colonized and we do not need to treat. However, if they have positive toxin production, then we know that they have active infection. And I really feel very strongly that this helps with identifying those who are truly positive and eliminating those who were previously falsely positive. So in the past, with that EIA test, like I said, if the antigen had been positive, but the toxin negative, it still reflexed over to the PCR. And if the PCR were positive, it would flag as a positive C. diff infection case, when, in fact, if they didn't have toxin production, they really didn't have active infection. So I think that was a huge step. And we did this both locally and regionally with our central lab. Then another huge initiative that we did that I'll talk about a little bit more in just a second is our fluoroquinolone initiative. So I would say for the past couple years, I've had my eye on a target of decreasing our fluoroquinolone usage. And I don't know what happened, but I think it was about Q2 of 2019, I said, you know what, I'm really going to focus on this. I'm tired of just kind of putting half of an effort toward it and working on other things at the same time. I'm really going to focus on this. I'm going to put other things on pause. And every time a physician orders a fluoroquinolone, I'm going to be right there looking at it and seeing if it's appropriate or not. And this actually goes hand in hand with the penicillin skin testing program that we did, and really getting out the word that, the cross-reaction of beta-lactams is not what we used to think it is. There's not the 10 to 15% cross-reaction. So I do a lot of education on when you do have to be worried about cross-reactions. There are certain cephalosporins that a patient could be truly allergic to, but you can also take another cephalosporin if it has a different side chain off of the beta-lactam structure. So we do a lot of education on that. And then just kind of putting out that word that, hey, just because a patient says they have a penicillin or a cephalosporin allergy does not mean that we actually have to go straight to the fluoroquinolones. So those two initiatives were big together. They really tied hand in hand. So I'll talk, like I said, I have a couple more slides in a second about that. And then our hospital also has a dedicated stewardship pharmacist that was really got going full blown in April. From there, in November, in October, we had new CAP guidelines that were published. So I've been working on educating physicians on, there used to be the old terminology of HCAP. And so physicians basically treated the same that they would as if a patient had acquired a hospital-acquired pneumonia and utilized really broad-spectrum antibiotics. So I'm trying to decrease our broad-spectrum antibiotics with the new guidelines for that. So I think that'll be very helpful as well. So let me go back a little bit and talk about fluoroquinolones. I'm not going to go through all of these, but fluoroquinolones class as a whole has the most black box warnings of any other antimicrobial class. So that gives us pause to think about whether we really should be using them or not, or just reserving them as very last case scenarios. There's also, this past year, they talked more about how fluoroquinolones are associated with high risk of C. diff. And interestingly, I was reading more about the hypervirulent strain of C. diff, or it's called strain 027, and it's the most toxigenic of the C. diff strains and has the highest mortality. And fluoroquinolones are the culprit of this hypervirulent strain. So these are some of the reasons why we really were taking a look at it. So again, looking at our MedMind tracking of fluoroquinolones at the top, you can see our graph of usage is the orangish line at the very top, and we were always above our competitors. So our likes or similar hospitals that we compare ourselves to is the green line, or non-teaching hospitals. So we just pulled away in Q3 of 2019, and then kept making a further impact in the Q4, and we really started pulling away even further of how much less we now use antibiotic or the fluoroquinolones than our national comparators. And in the graph below, I created a bar chart of 2018 usage of fluoroquinolones is in the green graph, and then 2019 is in the yellow. So you can see that we've kept trending down, 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 down. And most places look at days of therapy per 1,000 days at risk. So sometimes it's a little hard to understand, well, what does it mean that we went from 42 days of therapy per 1,000 days at risk to 33 in quarter 4? So I looked at it a little bit more deeply so that we could have a little bit better of appreciation of what that actually means. So from quarter 3 to quarter 4, that actually represents 195 less days of therapy, meaning that's how many less days of the fluoroquinolones we actually use. So that sounds a little bit more impressive, obviously, than 42 to 33. So breaking it apart, you can look at what our Cipro usage has been, and then also compared specifically to Levaquin. So every time I teach about fluoroquinolone use, the most common reason or appropriate reason to actually use fluoroquinolones is usually when you have a gram-negative bacteremia or Pseudomonas and you're switching to oral therapy to get the patient out the door a little bit quicker. Those are the times where you really could use a fluoroquinolone and it would be appropriate. And in those instances, we really want to use Cipro over Levaquin because it has enhanced gram-negative coverage and it isn't quite so broad spectrum. So our graphs are really trending the way that we want them to. And then also a lot of institutions, if you read the literature about decreasing fluoroquinolones or those places who put a restriction on fluoroquinolones, they also see a subsequent decrease in their C. diff, and then you can do a trend line to see. So I know this isn't the only thing that has caused our C. diff rates to go down, but it is interesting to look at our C. diff over time and then looking at the concomitant decrease in C. diff rates. So that's what we're comparing here. And then lastly, I was shared with the HIIN data of C. diff, and I thought it was really interesting. I was given the information that when we went from 2018 to 2019 and we decreased our C. diff infection rate by at least 40 to 45%, it actually is a $305,000 cost savings. It prevented 1,800 harms predictably and then 1 life saved. So I thought that was really cool to also put that up here just so everybody can kind of correlate, well, what does that mean exactly? So, and that is it.
Thank you, Laura. That was amazing work that you're doing, and I just wanted to point out that we were able to use that slicer to get your 2018 to 2019 data. Any questions there on your screen as she unshares her, you can contact her or one of us. And we're going to transition right now to surgical site infections.
Absolutely. While we're getting that intro slide back up, I have the privilege to support the surgical site infection work that we've done with you. And so I am very pleased to be able to introduce to you nurse practitioner Kim Reed, who serves as the nurse manager of surgical services and quality outcomes for Columbus Regional Hospital. And Kim, it doesn't seem possible that it's been a year ago since we first had our discussions when you were featured in our surgical safety event. So with that, we're excited to hear what you have to share.
Yes, so can you hear me okay?
Cutting out a little bit.
Okay, so now can you hear me?
A little better.
A little better, yeah.
A little better. Okay, let me know if an issue hearing me. Really, it's been a collaborative effort between, the surgeon's office, the surgeons, anesthesia, of course, all the nursing staff and techs, and just overall leadership to get us where we're at today. We still have a lot of areas that we're looking into to improve. Still hear me okay?
Yeah, it's better.
Okay. First, we really focus on our pre-op teaching with the encouraging patients, making sure they take their oral antibiotics pre-op as well as doing their HIPAA cleanse, and then we'll do the CHG wipes when they actually arrive in outpatient surgery. One thing we just started doing with our nursing staff is to make sure they're educating the patient on oral care. So that is one thing that we had not done in the past. Of course, we implement the colorectal bundle checklist. Another thing that we started actually today was typically I will round on the patients post-op day 1 in to make sure that they're using their incentive spirometer, they're doing the trachea breathing, that they're getting up and they're ambulating. And so what I've just started today was to go in and see them preoperatively in the room so that they make that connection. And I'll, again, reiterate the teaching that they've learned in PAT and try to connect back to the why. We also are working closely with our clinical review nurses and our infection control nurse so that if we do have an incidence of a surgical site infection, or as the clinical reviewers are looking at the chart and they notice that we've missed part of completing the checklist for the bundle, we'll circle back to that OR nurse, as well as if there is an issue, then we always relay it back to the surgeon as well. And again, any of this is, or all of this is reviewed at our quality and safety meeting that we have every other month, as well as being the surgical site infections are on our corporate scorecard. Another new initiative that we tried some new warming blankets, trying to focus on trying to keep the patient normothermic. So we're initiating that in outpatient surgery, as well as we're also looking at using a new device. It's called the 10-point endoscopic imaging system. And what this is it's a tool for intraoperative assessment of tissue perfusion during colorectal resection. It may lead to a decrease in incidence of an anastomotic leak. So that's our next kind of path we're going to go down with one of our surgeons. The other piece that we're really trying to focus on is just kind of getting back to the basics with the nursing staff. Again, making sure that they're providing the appropriate education to the patient, and so that the patient understands why it's so important, you know, why they do the incidence spirometer and so forth. And we will also, at our next meeting that we have, which it's twice a year, we have a meeting that has all of the surgical staff, as well as surgeons and anesthesiologists attend, mandatory, that we're going to share our SAR report from NSQIP. So again, so what can they do to influence and make a difference?
Thank you so much. Yeah, that's amazing. Yeah, thank you so much, Kim. We appreciate it. And we got to give you some love as well, because when we take a look at the project for your abdominal hysterectomies for the Columbus Regional team, your baseline period was calendar year 2015, and you only had one event. Since that time, January 2016 through January 2020, you've only had one event over that entire period. So I think that that's something to really celebrate. And then I know that you've done a great deal of work with your colorectal surgeries, and you pointed out some of your strategies there, but I wanted to give you all a shout out as well, because when we take a look at from June of 2018 through September 2019, that is 16 months that you had 0 colon SSI. So, and you're back down to 0 for January. So congratulations to you and the entire Columbus team.
Thank you. It's definitely a team effort.
Absolutely.
Thank you, Columbus. And now I'd like to turn it over to Brandy Nord, who's going to talk about patient and family engagement from Memorial Hospital and Healthcare Center in Jasper. And Brandy has many talents, as well as being the mother of new twins and a total of 5. So we respect you, and we'll turn it over. And that's a different definition of person and family engagement, but you go for it, Brandy.
Well, thank you very much. I appreciate it. Just wanted to give a quick snapshot of what Memorial Hospital looks like. We are a rural 137-bed hospital serving 8 counties, have approximately 1,700 employees right now, and we have 100 physicians who offer services throughout our organization. You can look there and see just a quick snapshot of our annual inpatient versus outpatient, 25% approximately inpatient versus 75% of it being outpatient services offered. And we do about 29,000 patients running through our ED on a regular basis. So we'll move on to the next slide. Another quick shot here just to show where we're located and the 8 counties that we service. Jasper, Indiana, Southern Indiana, a very strong German community, has a lot of organizations here to offer, and a lot of those organizations are very ingrained in what we do here at the hospital. Invested, they work well with us, and we work well with them. And then we'll go to the next slide, and that one there just shows very quickly our mission, our vision, our core values, the triangle pyramid, the way we have this structure built, just to reference the fact that our mission is at the base of everything that we do, and going all the way up, everything builds on each other, all the way to the top where we have our core competencies, one of which is cultivating collaboration, and that's for our patient and family engagement and how we develop this within the organization and the communities that we serve. We'll go to the next slide. And for this one, I wanted to just quickly focus on our Patient and Family Advisory Council. We have an advisory council that is led by myself, the Patient Safety Officer, and then I have a co-lead that is our Patient Experience Officer. The two of us take care of recruitment and retention and everything else that goes on with our advisory council. And that is the advisory council that comes to the organization, to our hospital, and meets on a regular basis. We meet quarterly for an hour and a half each quarter, and we review a lot of events that I'll get into later. In addition to having that Patient Family Advisory Council, we also have county councils in almost every one of the counties that we service, and those are ones that are that have community members, businesses, and then us as a hospital. We sit on that council to help support things that are going on inside those counties as well. So for our advisory council, we have community members that are on there, and we have workforce members that are on there. We try to do a good balance of who is represented. We obviously would prefer and we want to have more community members than we have workforce. And when we do select the workforce members that are on there, we try to be quite picky about who we ask to join. And it's mostly because we want to ensure that we have a good representation of what we can provide as an organization. So we don't want all nursing. We have representation from our outpatient. We have representation from nursing manager and frontline staff. So then when things are brought to the advisory council, whether it be questions or information, if any of our community members have follow-up questions or information that needs to be shared, we have the answers there in front of them, hopefully, that we can get this addressed and taken care of as it happens. With our recruitment and retention to have people join, when we first began and had an advisory council, recruitment was in the form of a flyer or brochure that was put in strategically placed in waiting rooms and areas, and we waited for people to kind of come to us and ask to be a part of it. It worked a little bit, not as much as we would have liked. So before I joined, they went ahead and did a complete revamp of our advisory council, created new bylaws, created an application process, and we began to actively reach out and recruit. We did this through our managers and directors of our inpatient and outpatient areas, asked for cases of patients and families who were actively involved, who sought care, who made suggestions, who wanted to be a part of what was happening in our facility. And then a piece that might seem a little untraditional, we also sought it through our experience officer for the family members or the patients who would call in with concerns or had experiences that were less than desirable. And as we worked through those cases with those individuals, if they fit the bill, we would ask them to join as well. Because not every experience is going to leave you feeling great, but if we can make it better and you are a part of fixing things, we want you to help us fix other things as well. So those were some of the ways that we would bring people in. Once we have them in and they're a part, we ask them for a 2-year commitment, meeting 4 times a year. But what we do is we will bring them information. We bring them information about new treatments and procedures and processes and certifications that we have going on here in our organization. and give them the opportunity to give us feedback as to where we need to go next, what we need to do, how we need to do things. We also bring them projects that we need their help with. We use them as our strong voice of our community. So if we are looking at trying to make something more patient-friendly or family-friendly, they are our first stop. We recently utilized them with a revamp of our patient discharge instruction and making sure that everything that is printed on there and provided to the patient and the family is one that can be read and understood by the patient and the family 2 days after discharge. And we found that having 5 or 6 medically degreed people writing these wasn't always patient and family friendly. So they tore it apart for us and put it back together, and it's made a huge difference in our patient satisfaction of understanding their discharge instructions. And not last and definitely not least, but these community members that are a part of this advisory council also get tapped to join our hospital teams. We run 90-day teams here. We do 5 to 7 of them every quarter. And oftentimes we need a voice of the community to come and sit in and fill it out for us. So a lot of times they will be the person that we contact and say, hey, can you come and join us and help us further? So they have set in on that as well. And as far as the surveys go, when we do our culture of safety survey, the organizational results that we receive, one of the first places that those results go is to our advisory council for their feedback and their input. They will select overarching themes that need to be focused on for our organization, and then we take those themes back to our leadership council and tell them this is what our community has selected and said is the important things that need to be focused on. And then our leadership councils will go out and build action plans built around that to help improve our results. We will also additionally, I'll touch very briefly on our bedside shift reporting because I feel like that's one of the key things that we started back in 2011 to help increase our family and patient engagement. Just the simple act of moving that shift report from the conference room into the patient's bedside has made a huge difference. We trialed it with templates so that nurses would feel more comfortable with the information that they were going to be sharing in front of the patient and the family. And then after that, we took it the 2 steps forward and went straight to the bedside. Family and patients are there. They have the opportunity to add information, ask questions, provide corrections if necessary. And that there has made a huge difference in the engagement and the buy-in from the family members and the patients. You will often hear patients say, oh, no, stay. They're going to be coming in. They're switching shifts. I want you to hear what my nurses have to say I've done. Or families will try to be here specifically at the times that they know we're going to do bedside shift report because that's when they feel they learn the most and have the opportunity to ask the questions with the nurses. And after a little bit of a hesitation on nursing's part, they have discovered that it is an amazing process for handoff and communication improvement from shift to shift. And it's made a big difference in that level as well.
Thank you, Brandy. That's just an incredible example of patient and family engagement actualized. And we can't thank you enough for your work on your Journey to Baldrige Award in 2018. And of course, if you want to contact Brandy, you can contact her. Let me know if you have any questions or any of us on the team, and we can sure get an email to her. And today they're sharing their Baldrige journey with the visitors on their to their hospitals. So thank you so much, Brandy. Good work there. We're going to flip through our slides pretty quickly here, and just a reference to what matters to you are some recordings for patient-family engagement that are available on the HIIN website about receiving, recording, respecting, and retelling the story. And as an example, this is what they've been doing through their Patient-Family Advisory Council. There are a number of additional PFE resources that are available that will be on the slide deck as it's posted on our website by tomorrow, including the ones that are listed here on the slide in front of you. I'm going to turn it over to Madeline now and let her talk about health community equity in your community.
Everyone, I know that we have talked over the last several calls about offering you to come to your hospitals to talk about health equity and how you can use Z codes for your social determinants of health, and that still is available to you. We are currently working on a data platform through DataLink, which many of you have just recently started doing. So more to come on that, but we hope to make that a self-serve so you can evaluate your data yourself through DataLink. And then leading a culture of safety, we have a mass group of people doing their culture of safety surveys during Patient Safety Week, and we're excited about that. The new survey so far seems to take about 7 to 10 minutes for average take time, which I think is a great improvement from the last one. And if you are looking to have a culture of safety survey coming up soon, please feel free to reach out to myself and Karen Kennedy, and we will get you taken care of. And now Annette's going to talk a little bit about telling a story.
Yeah. Everybody likes a good story, and oftentimes in healthcare we use charts and graphics, and we take these things to committees. And the improvement calculator has really helped us to connect a few more dots with the dollars saved, the harms prevented, as well as the lives saved, and that's most important, of course. But making it personal and connecting our purpose and the why behind what we do remains paramount. So always being patient-centered. So on the next slide, you'll see that we've been calling for case studies. And so these case studies, the template is here, and I do apologize. We've heard from some of you that the template was a little challenging in formatting, but Casey has worked really, really hard, and we want to extend our gratitude to her for helping with that. We've received 6 to date. So please know that our team is happy to visit with you or have a call to assist in completing this, because we want to hear your story. And so one of those stories might actually be, what you're doing for Patient Safety Awareness Week. And so that is just around the corner. Go ahead and advance that slide. And that's just around the corner. So hopefully everyone is aware that the Patient Safety Awareness Toolkit has been released, and it is just in a couple days. Casey Hutchins is your contact here for our team, and certainly if you have feedback regarding the refreshes that were made for 2020, we would love to hear from you. We'd also love to see your pictures of what you're doing in your own communities as well. So as Karen mentioned at the top of our time together today, the Indiana Patient Safety Summit is slated for May the 19th in the same location where it was held last year. So please do mark your calendar. More information to come with registration. And then finally, our team is available. All of our contact information is here for you. Thank you on behalf of everyone for giving us the privilege to serve you and walk alongside this very important work. You're making a difference every single day, and I think we heard 4 beautiful illustrations from our presenters today. So again, thank you to LaWanda, Laura, Kim, and Brandy. And with that, we wish you a great day.